Good evening, ladies and gentlemen, senior members of the profession, colleagues, and other allied healthcare professionals. Welcome to today's webinar on Part 3 Antimicrobial Stewardship Programs, hosted in partnership between Pharmaceutical Society of Kenya and MTAPS. Ladies and gentlemen, I want to welcome you all. I can see senior members of the profession are joining in. I can see Dr. Joseph Esekon all the way from Turkana with the Javan Inda. Asanteni sana for joining us all the way from Turkana. We give our members probably 5 minutes, between now and 7:05, for us to be able to begin. I want us to have at least 100 attendees. Today we're going to have a great presentation, and I want us to at least be full house before we begin. Asante sana, all the senior members I'm seeing. Dr. Jesse Mukuria, asante sana daktari for joining us this evening. Asanteni. So, ladies and gentlemen, I will remind you that the event is on the PPB portal. Kindly remember to subscribe to this event. However, there is the disclaimer that all events CPD tokens are only issued to PSK members. But for these, you can attend when you've not updated your membership, but you can still update your membership so that you allow yourself some time to get back all the CPD points you gained. So ladies and gentlemen, kindly remember to subscribe on the PPB portal for this event. We're having a week fully packed. It's not even a week, it's probably 2 weeks fully packed with webinars. Between now and the 16th of December, we are having close to one webinar each and every day. So ladies and gentlemen, kindly subscribe. Thank you very much, Dr. Naomi Irongo. Asante to join. Dr. Oscar Shamala, all the way from Turkana. Today we're having 3 pharmacists from Turkana branch online on our webinar. Asante Nisana for making time to join us. It's a polite reminder that kindly subscribe on the PPB portal. Kindly subscribe on the PPB portal. All our events are there, and that way we're going to be able to award you the CPD points. And also remember, members who have not updated their membership, kindly expedite your membership for 2020 because nyumba yako usipoichunga nani ataichunga. So kindly members, allow yourselves to even pay up the membership, even though 2020 is coming to a close, for us to be able to manage, to be able to run the society well. Asanteni for the support the whole year. I've seen we're now headed to 100, and I'll ask for your permission to begin. I can see Dr. Esther Mokai is here, Dr. Rosaline Kinuthia, that is Nairobi branch. Asante, Dr. Shital Shah, that is Nairobi branch, University of Nairobi. Asante sana, Daktari, for joining us. And I'm also requesting probably also for the participants who are joining in to kindly also name their Zoom login they have joined in. I can see somebody known as Technocam on 12. Of course, it's a great phone, but give yourself a name so that we are able to give to award you the CPD points easily. So, ladies and gentlemen, without further much ado, I want to call upon our moderator for today, who is none other than Dr. Collins Jaguga. Dr. Collins Jaguga is going to take us through. Today's webinar. He has been taking us through the previous webinars with MTAPS. Dr. Collins Jaguga is a senior technical advisor at Medicines, Technologies and Pharmaceutical Services Program, Management Sciences for Health. He is a pharmacist, a member of PSK, and a devoted pharmacist for that. He owns the profession. So, Dr. Collins Jaguga, are you with me?
Yes, I am. Thank you very much, Gitao. Good evening, PSK members. As mentioned, my name is Collins Jaguga, a pharmacist currently working with the Management Sciences for Health and implementing a USAID funded program known as Medicines, Technologies and Pharmaceutical Services that uses the acronym MTAPS. So MTAPS is a 5-year program whose main goal is to support the Ministry of Health to implement its National Action Plan for the prevention and containment of antimicrobial resistance. The AMR National Action Plan envisages developing the capacity of healthcare professionals on antimicrobial stewardship as a strategy to prevent and contain AMR in Kenya. So USAID MTAPS program has partnered with PSK to sensitize its members on antimicrobial stewardship. We are having a series of talks that began about 2 months ago, and we will have a few more in the next couple of months. Today, we will have part 3 of this series that will focus on the core elements of health facility and antimicrobial stewardship programs. And to take us through this session is none other than Dr. Dorothy Aywak from Kenyatta National Hospital. Dr. Aywak is a pharmacoepidemiologist with over 15 years of hospital pharmacy experience. She holds a Bachelor of Pharmacy and a Master of Pharmacy, Pharmacoepidemiology, and Pharmacovigilance from the University of Nairobi. She is also a member of various professional associations, including PSK, the International Society of Pharmacovigilance, and the International Pharmaceutical Federation, FIP. She currently also serves as the Secretary of the Hospital Pharmacists Association of Kenya. It's worth noting that Dr. Aywak has worked at KNH since 2005, where besides managing the outpatient pharmacy services, she is the hospital's pharmacovigilance lead. She is also a member of the Medicine and Therapeutics Committee. She is secretary to the Antimicrobial Stewardship Committee, among other responsibilities in multidisciplinary teams. Dorothy is passionate about building a patient safety culture among healthcare professionals through facilitating various training programs. She is also passionate about training and mentorship. Welcome, Dr. Aywak, to take us through this session.
Thank you very much, Dr. Jaguga and Mbao, for the kind introduction and even the opportunity to come and share with the members today. First, I want to confirm that actually I am audible enough. Collins,
Yes,
am I audible enough? Okay, thank you so much. So today's topic is part 3, the series on antimicrobial stewardship, and I'm hoping that we can have this closer to just a thought-provoking, or even just trying to think of how we can live here, not just to be looking at the slides, but with an action step of what it is we're going to do in our various facilities or practices. So this is the, I'm going to use this, okay, as I think I'll have to stop share and renew this and start the slides again. They were just working a few minutes ago. So, but, okay, finally. So the objective that we're going to, the objectives of this presentation, as you can see on the screen, is that we are hoping that you'll be able to know what are the core elements of the MS program. There are 9. So we're hoping that at the end of this, you will be able to outline, highlight what are these core elements, look at how the leadership and governance structure is for AMS, talk about accountability, drug expertise, and actions. We look at the reporting, monitoring, evaluation of AMS data, and how we are going to communicate and advocate for quality improvements. This outline is actually the 9, highlights now the 9 core elements of the antimicrobial stewardship. Now, where it is are we concerned? This week that ends today, rather the week that started 18th and ends today, 24th, is the World Antimicrobial Awareness Week. And this week is trying to bring attention for the public, the health workers, to the problem of antimicrobial resistance. And what brings about this? We know that antibiotic misuse is one of the contributors for the same. So studies have shown that approximately 30% of antibiotic prescriptions are either unnecessary or inappropriate. As part of the activities that KNH, my institution, carried out in marking the week, we also undertook a survey targeting the public, where we wanted to just have an idea of the practices, the knowledge, attitude, and practices around antibiotics. And from the study findings, we had 239 respondents. We were hoping if we would reach 3,000, but from the 239 respondents, we found that majority of people are aware that actually about the issue of antimicrobial resistance, but now we find in terms of how do they use medicine, we find about 30% had reported that they had actually would have used an antibiotic for colds and flus, although and 80% would have said that they know that antibiotics will not be useful for treating viruses. So you notice that even in the public, even when you know something is not going to work, you still, antibiotics still seem to be what most the public runs to. And I think, well, we can include ourselves in the public in that statistics when it comes to how we interact with antibiotics. So what happens? Most of the time, you give an antibiotic when they are not needed. I'm sure when they are running for the antibiotics, they're coming to us. You may continue them longer than necessary or give the wrong dose. So we need to start thinking, what are we doing? In terms, we're saying the public does this, but what are we doing that we contributes to this? Are we not giving the right instructions of how to give the medicine? Are we not telling them about the correct dose? Are we not selecting the right choice of antibiotics? So we use broad spectrum agents to treat very susceptible bacteria that you can use a narrow agent. So what happens? What's the consequence of inappropriate use? We know now definitely use an antimicrobial agent improperly, then we have the risk of antimicrobial resistance. And now this is going to come now and have a snowball effect in management of other conditions. When you're having patients who are on cancer chemotherapy, we know they'll tend to be immunosuppressed. So we might decide, let's just cover them with an antibiotic so that we can make sure that they have good cover, they don't get infected. But now, when their blood counts are low, will they actually even be given the treatment that they require for the cancer chemotherapy? When you're looking at the TB, malaria, when we start using medication inappropriately, it's going to have an impact on whether we are going to manage these conditions. These are communicable diseases well. Then the effect on now in terms of healthcare costs, you're going to have to use higher, broader end, probably more expensive treatment to manage the condition that you'd have used a simpler approach. And this also inadvertently exposes the patients to adverse events, because when you're using a newer molecule or a different molecule, then there could be a potential of adverse events. You might not even be very familiar with that new molecule. So what do we do to make sure that we stem the tide of antimicrobial resistance? One thing we can do is have antimicrobial stewardship programs so that we start thinking of how to be guardians of the antimicrobial. So what is a stewardship program? As you can see highlighted on your screen, it's an organizational system-wide healthcare strategy. Meaning there's a plan of how you're going to do this to promote the appropriate use of antimicrobials through implementation of evidence-based intervention. So you're not going to just shoot in the dark. We're going to see what has worked in other places, and then we try and domesticate that to our setting. What are these 9 core elements? The core elements of our hospital antibiotic stewardship program. I think even if you may not be practicing in a hospital and you might be in community setting, you could be able to actually capture some of these points and see how you can customize them and implement them in your practice. So we are looking at leadership and commitment. It's important that we have a good leader structure in which you're going to have the stewardship program. If I give the example of my facility, KNH, the antimicrobial stewardship is a subcommittee of the larger medicine and therapeutics committee. And it is, the committee actually has a responsibility to report to the senior director of clinical services. So now you have the larger docket so that you have an accountability system, and also you have buy-in from the leadership to make sure that any interventions or activities that you plan, they are plugged into the larger hospital structure. And now that will give you a chance to think, if your AMS, if you have AMS committees or you want to set them up, you need to start looking at how do you link them up to the larger governance structure of your facility. Then there has to be accountability, because if nobody is going to be watching out for what it is you're doing, then now there's not, you are not going to be achieving, you'll not be encouraged to actually achieve any interventions, any target. You're not going to feel pressure to undertake any targeted interventions. This drug expertise, the actions and interventions, we look in more detail at these 9 elements as we proceed. So starting off with leadership and commitment, like I said, it is good to house it in a structured manner. So here you're starting to look at what are the formal statements that the facility supports efforts to improve and monitor antibiotic use. If it's a committee where it is just that it is left on its own and it is up to you to figure out how, if you propose, say if you propose you're going to have a policy on restricting antibiotic use, and it's left to the committee to figure out how that is going to happen, but you don't have the leadership to support the implementation, then it ends up being like shooting yourself in the foot. And then it's important that when you have the members of the team having stewardship related duties, that let them be written in their job description, and then you can actually have performance reviews which are based on their stewardship related activities. Because again, what you don't measure, you will not do. What doesn't get measured doesn't get done. And also to encourage people, because taking part in committees, antimicrobial stewardship programs is actually quite engaging and requires you to put quite a lot of effort. So if it doesn't fit in your main job description, it looks like a side hustle or side task, then it will be difficult for that program to succeed. So staff, this is a multidisciplinary committee, so you need to make sure that staff from all the relevant departments are actually given time to be able to contribute to these activities. And we know we don't wake up and we suddenly are aware of all the stewardship, what is expected of us. So we need to be able to support them with training and education. And this is why it is important that the management takes it up and supports the stewardship programs, because now we will require the management to support education and also to finance its activities. If I give the example of just what we've gone through this week that is ending today in terms of the World Antimicrobial Awareness, we had got quite a good support from our Chief Executive Officer when we came to looking for now funding or requesting for a budget to be able to have the public awareness activities. So the budget might not have been much, but at least there was an effort to see how they can help us to be able to mark the week and at least spread the message out. Now there's governance structure both at national level and subnational level. I will display a slide of how this works and this, so that now what we do as a facility, in terms that this information finds a way of cascading up to the national government, so that now it is used in policy making. So this is a slide. It may probably not be very clear. I want to hope that when PSK circulates this, you can be able to get it in a bit clearer version, but it's demonstrating that we have all under the Ministry of Health. So you have your under the Ministry of Health is the National Antimicrobial Stewardship Interagency Committee. There's the National Infection Prevention and Control Advisory Committee and the National Medicines and Therapeutics Committee. Now in the national structure, we have the National MTC and the National Antimicrobial Interagency Committee just right under the Ministry of Health. So you can see how that can work in your facility. For our facility, we find it better to have it just right under the MTC. Then under the National Antimicrobial Stewardship, there is the county system. And from the county, we have the sub-county all the way to health facility. This structure, I think, is quite familiar to those who particularly are in government sector, but I'm sure even those who are in private will have a way of being able to participate, whether it's within the counties or in the national setting, and eventually we all contribute to the Ministry of Health, which supports our activities. So when we're looking at accountability, it is important to make sure that we have a single leader who will be made to be responsible for the program outcomes. So everybody's work is nobody's work. So there has to be somebody who we identify as the program lead. And studies have found that infectious disease physicians tend to be highly effective in this role. And to make sure that they actually committed to the program, it is important that these activities are also incorporated in their performance appraisal systems, so that it can even motivate somebody to work in that program. And the ID physician cannot work alone. The pharmacist expertise is vital. The stewardship program cannot go anywhere without pharmacy expertise, because the pharmacist is held accountable for implementation of the MS program. You can think if it is in terms of the leadership of the UK, we have the Queen, the figurehead, who everybody will look at, and then we have the Prime Minister who runs the show. So we have here pharmacists who basically run the show. Now, when you're looking at the element of drug expertise, what do you do as a pharmacist in this program? So you are responsible for leading the drug expertise, and you're leading the rest of the team, which is in your AMS. So you have your medical specialist, your depending on your facilities, you'd have the medical officers or clinical officers, you have the nurses. We cannot disengage antimicrobial stewardship from infection prevention. So it is important that you have that representation in your committee, quality improvement, laboratory. Now, the pharmacy and lab is very key in terms of being able to gather data to see what structure your interventions, and IT. IT will be able to support you when it comes to data collection, data analysis, even cascading your preparing how you're going to communicate your interventions. So what do you need in terms of pharmacy expertise? You need a single pharmacy leader. So I will keep giving examples of the setting that I practice. There are 4 pharmacists in the AMS committee, but we have identified one. In our case, it's Dr. Rosalind Kinuthia, who is the single pharmacy lead. That's a person who will say this is responsible for making sure that they look at the element of drug expertise. That is a person who's held accountable. And they need to have, it's good when they have some formal training in infectious diseases, because when you think about it, where are you using the antimicrobial agents or antimicrobial stewardship program? Now, I would say not to worry if you don't have formal training in infectious diseases. I'm sure there are quite a number now with the online platform opening up that you can use to be able to boost your knowledge. You need the medical officers, the clinical officers to be part of this team, because they are the ones who generate the prescriptions for the antimicrobial agents. So they need to be fully engaged to make sure that they actually prescribe in a manner that is going to promote appropriate use. The infection prevention and control personnel, they're the ones who conduct surveillance for us. So they need to be able to be looking out what is happening on the ground, trying to monitor and look at the trends of healthcare associated infections and bring this to the attention of the committee. That way you're able to get targeted interventions. If they start reporting, we are having a lot of we are noticing a lot of MDR bugs, maybe Klebsiella is not responding to treatment. Now this needs to be brought to attention so that action can be taken. You find out what is happening, what is the problem on the ground, the root cause, so that you can be able to remedy the problem. And they are very important for supporting implementation of strategies to optimize the use of antimicrobials. What is the work of quality improvement staff? So you will ask, who are the quality improvement staff? They may be maybe the patient safety team in your hospital or something similar, or quality assurance. So this member is very key to make sure that you're actually always looking at, are you adhering to your standards? Have you set standards and are you adhering to them? And for the quality improvement officer, safety is a very key issue that they monitor, because even when we are saying that we are going to have a restriction policy, was your restriction policy going to cause that they'll be interfering with the quick start of treatment for a patient who actually genuinely needed maybe the restricted antibiotics? So now patient safety is key. So even when you're doing the policies, the QI staff, the quality improvement staff will be looking at that angle. You want to provide care using best practices, and you need to give it in a system that is safe, that is not going to deny care when you're trying to hang on to your agents. The laboratory staff are very key to provide us information on what are they growing, what are they noticing when they are getting the samples for culture and sensitivity, so that now the reports we are getting from the lab will help us to be able to determine what would be the best empirical therapy. As you know, a patient will come and will not likely wait for the culture and sensitivity to be done, so that now you give the antibiotics. But now if you have data that's already collected about what is the picture you see, so you know when a patient presents probably with a blood infection, with maybe UTI in your setting, what is the best choice to start with, so that we reduce the guesswork. So laboratory and stewardship staff work collaboratively to ensure that the lab reports presents data in a way that will support optimal antibiotic use. So even when the report comes, you need to be able to understand, what does all this MIC mean? What is the implication? So they need to break it down to help us utilize the information, as well as give education to the various teams on what is the best practice for specimen collection. We recently had a session where our clinical pathologists let us know that most of the time when samples are being taken to the lab, and they are from catheterized patients, sometimes you find that it's a bit of the catheter that is cut, and whatever growth is there is what is actually sent to the lab, as opposed to going direct to the source of where you expect the infection and not withdrawing it from the catheter. So the lab staff will be able to give the best practices on specimen collection. And now we come to information technology team. They're critical in being able to integrate stewardship protocols into your existing workflow, whether it is by being able to take your guidelines and digitize them to help you circulate them, and this will be able to assist in clinical decision making. Whether it is you're going to have prompts on your systems, if you're using a lot of digitized system to be able to manage your medical records, then they can be able to incorporate prompts that can help you to be able to review the antibiotics in key situations, as well as facilitate collection and reporting of antibiotic use data. Like recently, we found that they are very key in being able to help us collect data and analyze it. So that you remember, we don't want to carry the whole load. As much as pharmacists is key, you don't want to carry the whole load of the stewardship program. You engage others in their intrinsic skills to be able to give you the data or synthesize the data for you so that you can be able to get your interventions. Then the nurses here are very key because they're the ones who are going to administer. They're going to actually implement what it is that you set out. If you've decided it's restriction policy, they're the ones who are going to be your champions in the wards, in the clinics, to remind people what are the guidelines. What do the guidelines state? When it comes to managing various conditions, what are we supposed to do? If you have restriction policies, how are they going to support you implementing those restriction policies? If you require that medication is reviewed every week or every 5 days, they're the ones who are going to make sure that the clinicians will make sure that that review is done and any necessary documentation that has to accompany a request is sent appropriately. So it's important to have nurses who are quite invested in the process to ensure that they help you implement the processes, the activities that you have set out to do as a stewardship team. Now, when we look at the next core element, the actions and interventions. So you start thinking in your facility, what policies can you come up with that can be able to support antimicrobial antibiotic use? So do you have any policies that are relating to antimicrobial prescribing? Have you decided what can be prescribed at what level? Do you have facility-specific treatment guidelines? Now, I'd want to emphasize in that point that many times, like I'll give a setting, maybe in my facility, KNH would come up with guidelines, but it's based on the data that we have. So can you immediately transfer that data and say that the patients you have in Turkana, you will use the exact same guidelines? You need to look at how do you domesticate, how do you maybe borrow how those guidelines were developed or even the layout, and look at now, you generate your data, what are you seeing? Because if you imagine if you expose, the facility is a level 6 facility, if you expose a patient who is just coming straight from the community to the treatment guidelines of somebody who you're expecting at level 6 has already passed through the various level of the healthcare facilities, then what the good thing that we're trying to do with the guidelines to guide therapy in the referral hospital will end up failing. Because when we are thinking they're coming fresh after passing through the lower level facilities, instead they've been hit hard already at the beginning. So it is important that when you're looking at treatment guidelines, see how you can customize them, find out what is it that is happening with your population and use that to generate. You can use the guidelines, the national guidelines or other facility guidelines to give you an idea of how to structure your own. Looking at the interventions to improve antibiotic use, I think for private hospitals, they have been very good at establishing antibiotic timeouts. So you need to think in our settings, is it possible to make sure that you have set out that you're not going to give an antibiotic more than 7 days, or is it more than 5 days? If it's a restricted antibiotic, are you going to say you'll only dispense for or have it administered for 3 days before now you have to insist on any clinical justification? Is prior authorization required for certain medications? And then when you conduct the audits that you may do, maybe you want to look at an audit, we usually plan to do an annual audit on restricted antimicrobial use to see whether when we say we are restricting, are we actually seeing the consumption going down, and even that it's being prescribed to those who actually require it. And now this feedback you need to give also to the clinicians and the various areas, to the nurses, so that we can see how well our interventions are being taken up. Then you talk about if you have automatic changes, dose adjustments, automatic alerts. There are a number of interventions that you can put in place, and you need to think, what is it over here that you can adopt? You can just pick one, whatever low-hanging fruit that you can identify and try and put it in your, implement it in your settings. Other interventions would include time-sensitive, okay, that was highlighted at the time-sensitive automatic stop orders, the detection and prevention of antibiotic-related drug interactions. So now that means you need to review treatment sheets and prescriptions to check, are you having any potential interactions that you need to be able to address? And then also when you're looking at infection and specific interventions, can you get guidelines or guides that can be able to guide what do you do when you have a patient with community-acquired pneumonia? I think yesterday with the PSK and GSK, there was a good presentation of managing community-acquired pneumonia. And look at what are the common conditions that you're experiencing in your facilities, and what can you do to put specific interventions or guides that can tell you how you're going to manage patients who have those various conditions. And now it's also important that once you have this, then you need to be able to report. Because again, if you don't say what you're seeing on the ground, if you don't report to give this information to the doctors, the nurses, all the staff who are involved, if you don't share this information, then you're not going to be able to change practice. And what you can do, look at consumption and resistance trends. This is a very good guide to give you an idea of what is, you say that you're looking at monitoring antimicrobial resistant and antimicrobial consumption or use. That gives you an idea of what to expect. If you notice you're having a high consumption of probably a restricted item and the narrow spectrum are rarely prescribed, then you look at also resistant trends. Are you encouraging resistance by that inappropriate prescribing, or is that consumption having a link to resistance? Because we find sometimes when the lab reports that they're starting to note that there is resistance developed to ceftriaxone, and when you look at the pharmacy, the consumption data we are collecting from the clinical areas, and you find we've actually been using a lot of the ceftriaxone. So you tend to find this, when you get this data, you can be able to correlate the two, and you can ask yourself, well, let's go back to our guidelines. What does it say you need to use for UTIs? Are we treating everybody, say, with a cephalosporin? Are we, is somebody supposed to be on maybe erythromycin, and you don't like the thought of taking it every 6 hours, so you decide to give a quick shot of ceftriaxone and send them home? You need to think, when you are reporting, this is done basically so that you can be able to evaluate what it is that the activities that or the interventions that you've put in place. For this, you actually require good documentation of the treatment indication for the prescriber. So if you're using a treatment sheet, and I will keep giving an example of the facility that I am in. In KNH, the first treatment sheet was redesigned so that now when you're prescribing the antimicrobials, there's a particular section for antimicrobial therapy. And there the prescriber is required to indicate, is it empiric, is it prophylactic, or is it now for definitive, that you actually know what it is that is you're managing. And many times if you have that ticked out, then you can know very clearly what it is you need to give. I want to hope that the background noise in my area is not interfering with the presentation. If I just take a moment, if Bao can confirm that at least you're not getting a lot of background noise from my area.
No, there isn't, Dorothy. You can proceed.
Okay. Thank you. It's called the challenges of presenting from home. Then now we look at monitoring and evaluation. Again, as I said at the beginning, what you don't measure, you will not do. So you need to be looking at, so here we're talking about monitoring antibiotic prescribing, so that you can be able to know what are the opportunities for improvements that you can identify. So again, I'll just keep giving as a disclaimer that I will keep giving scenarios from my practice setting, because now that's where because that is to make it easier to probably see what you can pick up. So we noted when we measure antibiotic prescribing, we noted that uh, the pediatric department would consume considerably higher amounts of, say, meropenem than our critical care at the start when we're measuring. And we're wondering, why would pediatrics use much more meropenem, and you're expecting you have children who everybody will be sepsis or maybe a community acquired infection. And critical care, where you're expecting that, of course, now there's more severe illness, is where you'd expect to see higher consumption. But now, as we noted that, we got in touch with the pediatric team to identify what is the problem, narrowed down that we are having the issue mainly in our newborn unit, sit down with the newborn unit and find out what is the problem. And we found IPC practices needed to be reevaluated, and also just sharing the knowledge and bringing to the attention that not when you see a small baby, the thought of a small sick baby, we need to hit hard, and then from there now you hope that the outcome will be much better. And I'm thinking this is a small child who has not been exposed to, since well it's a newborn, you don't expect that they have been exposed to other treatment. So even a narrow spectrum would work just as well, because they don't have a previous antibiotic exposure. So when we bring this information to the team, we started to notice actually now, as we monitored the consumption and the following quarter, that there was an improvement, that the consumption started going down. And so there are those areas we can decide if it is a certain level, if you decide to categorize your drugs, like the WHO gives the AWARE classifications, what is for access, what is to watch, what is to reserve. If you're finding that you're not consuming a lot of access medicine, you're using a lot of watch or using a lot of reserve, it means that you need to do something, and you monitor and check and give this information, because sometimes it is would say it's the fear of the consultant that makes the doctor decide what to prescribe. You don't want to be told that you did not manage appropriately, so you think the best thing is to hit hard. Me coming from a training institution, you find that you have that as a challenge that interferes with our antimicrobial prescribing. So when you measure, you're measuring to evaluate both the process, that if you have guidelines and policies, are they being followed? And when there's an outcome, has that intervention that you've put in actually improved antibiotic use? So in terms of policies, as a hospital, we come up with antimicrobial policy that we're working on and once it's ready, I think it will be easy to be accessible by everyone, that then you can customize it or develop one for your own facility. And then we have guidelines for empiric therapy, which we want to update based on what it is the lab has said. Remember, the laboratory team monitors the resistance patterns, and it's this information that we use to update our guidelines. Then, or is it an outcome? Have we said that now there will be no issuing? For example, we say for surgical prophylaxis, we've insisted that for surgical prophylaxis, the best therapy is cefazolin. So therefore, we should not have a patient going to surgery with a different antibiotic prescribed as prophylaxis, unless now maybe that was an antibiotic that they were on treatment on, and so now they are just continuing the dose. So we look at, when we check our theater, we see, has this intervention actually improved antibiotic use? Are we seeing less variety of antibiotics being brought with the patients to theater, and we are having adherence to what it is we had instituted, what it is was recommended? So process measures, these are prescribers accurately applying diagnostic criteria for infections, are prescribed recommended agents for a particular indication be given, like I gave the example of for surgical prophylaxis, we have a recommended antibiotic. Is that what we are seeing? Are we seeing documentation of indication? The treatment sheet has given the option that you can, not the option, has given the space that you need to indicate what is the indication. Is it empiric? Is it prophylactic? So that one can help you even when you're reviewing treatment, just to know this one is actually, there's results to support why a certain antibiotic is being given, or this is a prophylaxis, therefore you check with the guidelines for, is it a UTI? So what was recommended for UTIs, and is that what is actually being prescribed? The process is cultures. Are cultures actually being done prior to treatment? When the antibiotic is being modified, is it based on anything? So those are process measures that you will look at. Outcome, you're looking at, so like what I had mentioned, what the intervention we had for our pediatric department, we started seeing a reduction in the carbapenem prescribing, and for us that was a win. And now that we see that there will be a reduction in antimicrobial resistance, because you'd expect when the lab starts giving results, when they are getting the samples, then you will not be picking up resistant bugs from the lab, and this eventually will be cost saving and decrease hospital stay. Next, we'll look at education and training. So it is important that you continue to engage your health care workers, the staff, the team that you're working with, issues regarding antimicrobial stewardship, and also keep talking about antimicrobial resistance and improving both the prescribing and dispensing practices. If we say that you see a treatment sheet and the duration is not indicated, don't give until we have the treatment sheets keep on being renewed. If we can find a way of being able to check how long has a patient been on treatment, and you don't give a patient, will say from the day they were admitted to the day they were discharged or on a particular antibiotic. We also need to be good stewards and actually check, does that patient require that medicine? And where it is clear, like most hospitals, I think you would have segregated your patients. You know where the surgery patients are, the medical patients. So you can almost tell from the order, this patient is a surgical patient. Would they have just required only prophylaxis and yet they're on treatment? Do they actually require that as treatment, or do you need to alert the clinicians that they need to stop? Because this is just, we needed only give prophylaxis, there was nothing to treat. And we need to keep on educating our patients and family members. So part of this week, I hope in your various facilities or wherever you are, you found a time to talk to family and patients and just give them an idea of what it is they can do to be able to preserve the antimicrobial agents. You can do this in various ways: posters, flyers, newsletters, electronic communication. We were very fortunate to get some videos from the REACT group, the antimicrobial resistance group, which we said we'll share on the social media and hope that we can spread the message out. We around the hospital put up posters with different messaging around the area of antimicrobial resistance and stewardship. So you look at in your facility, in your practice, what can you do to be able to share the message? Or when a patient is coming to your facility and they are fearing that they could be having some infection, and you can assess and find maybe possibly it might just be a flu or something viral. What advice can you give them? And even going forward, what they can tell the rest of their family members so that they will not rush they'll not call you and tell you, my father at home is feeling sick, so which antibiotic do you think I should buy and send home? When you give the right message, you end up cascading, and the message snowballs to there. You say we use the snowball effect of having the message get down to the grassroots. Look at the element of communication. Here now it'd be good to design this one. You need to look at what multiple ways can you use, what different media can you use, what channels can you use to spread the message, and you target the message. So if it is hospital setting, you probably want your health workers to utilize the laboratory more. Can you structure your messaging that way? If it is that we have guidelines and they're not using them, can you structure them? You look at what is the audience you're looking at and you structure the message. Even when you're doing your data collection or just assessing, doing audits to identify the problems in your facility, you structure the message. If it's a pediatrics, you see how do you find out what speaks to them, or even who is the best person who is the champion to identify, so that you can be able to spread the message. If I go back to the example for pediatrics, we identified the pediatrician that they have great respect for, bring her to the meeting, share what it is you found, and then now when they had the pediatrics grand round, you have co-present with that pediatrician, so that now you pass your opinion and they're listening it also from somebody who they value their opinion, and that way you're more likely to have an effect. And when you're evaluating, you can evaluate, you're supposed to evaluate in phases. so that you can see what you don't wait for 6 months or the whole year to see whether your intervention works. You can say after 3 months, I want to see, do I need to make any changes to my plan so that now I can make sure that my end goal of ensuring an appropriate antimicrobial prescribing or use is actually achieved. We come to quality improvement. We said quality, if you don't measure and you don't get some standards to be able to base your interventions on, or to be able to monitor your interventions, you'll not know whether you're meeting targets or not. So it's important to incorporate quality improvement in your AMS program and ensure that you're always improving your interventions, and even the ones which you have put in and you see they have succeeded, you put in steps to make sure that they are sustained. And any changes and interventions need to be tested with experiential learning methods before you permanently implement, meaning that just try, I'll go back to when we started the restriction policy. We said if we try to tackle the whole hospital, first we may get a lot of resistance, and also we don't know how well it will work. So we decided we'll start with surgery. And we had the surgery representative, we have a surgeon in the MS committee. So now that one would be our champion in that area, that so that when the surgeons start complaining, why are you restricting? We have somebody who speaks their language who can explain to them the importance of AMS, of the intervention. And now you check, is it working? And now from the lessons you learn from there, now we cascade, now we move to pediatrics, we move to reproductive health, move to critical care. So it's important to look at when you implement, learn from it, and then now cascade it, and now you cover your entire facility. So this checklist, I'm hoping it is clear, but it's good when you have set up your antimicrobial stewardship committee. It's good to evaluate first, do like as a baseline, to look at, assess how does your stewardship program look like. So here, if you're assessing based on the 9 elements. If there's leadership support, now here you'll ask yourself, does my facility have support from the leadership to be able to improve antimicrobial use? So you're starting, yes, I have, no, I don't. So that from there you can know what you need to do so that you can get that support. If the support is there, maybe by word of mouth, but there's nothing formal documented, we insisted that we are excited that ours, we have a direct responsibility to the senior director of clinical services. So we need to succeed, and some of what it is that is of our activities will be measured when the director of clinical services is having to be evaluated on his or her, on her targets. So now there is a vested interest to make sure that as a committee, you actually also succeed. Do you have financial support? If you don't have, what can you do? Accountability. Do you have a physician leader who's accountable? So now this tool, I want to hope it will be easy to access or distribute. So probably the MTAPS program can be able to help distribute these tools so that you can assess before you start, or even for the programs which are there, you look at what you have, and that helps you know what kind of support do you require to have a well-functioning program, stewardship program. I want to believe that that is the last slide. So the references for this are here, and I want to thank you for giving me your attention. And I think we can be able to move to the question time. I should hand over the meeting to Dr. Jaguga.
Thank you very much, Dr. Aywak, for your very comprehensive presentation and for sharing very, very informative insights, I must say, from experience at KNH. There's a comment here from Nandi Phillips saying very informative and relevant presentation addressing AMR as well as effective use of antimicrobials. That's a comment. There is a question from Velma Nanyama. Well, a comment and a question. She says very insightful presentation, and she asks, for smaller facilities with no MCS facilities, I'm not sure I know what MCS facilities is, what is the best approach to antimicrobial stewardship? What is practical in their scenario? So for facilities with no MCS facilities, what is practical in this scenario? I don't know whether that acronym is familiar to you.
Unfortunately, I'd hope Velma can clarify what is MCS. Is it microbial culture sensitivity? We know microbial.
Maybe if you could just type it, Velma, if you could expound it. appreciate. I'll go on. Kefa Mogere has a couple of concerns. I will try and then summarize. Well, one, he says good presentation and initiative, and then some of the problems that we are facing nowadays in practice are, number one, lack of commitment from our senior colleagues who insist on no substituting. Secondly, there is inadequate infrastructure in most of our healthcare facilities, especially in the laboratory sections, so that even simple tests like a full hemogram cannot be done. He goes ahead to say that there are inadequate qualified staff, I believe, with regards to, AMS work. We are very frustrated working for the government at Mashinani. Do you really have hope to effect antimicrobial stewardship? I'm almost giving up. So, Dorothy, I know you're a part-time motivational speaker. You could encourage people. Is there hope?
Okay, that was Kefa.
Yes,
I almost feel his pain. I'm not a motivational speaker, but I would identify with the challenge because now it sounds like everything is nice and rosy now when from the presentation. But our AMS committee was set up in 2013. For starters, probably even consistency in meetings was not there. So even when you want we want the physician leader to be able to promote the interventions that we suggest, you may find, okay, yes, he was very good. The committee before we currently have Dr. Cheng, we had Professor Omonge before. He'd be very good at sharing, and I think those who have listened to him know he's a very good teacher. But we also needed somebody who is also a pusher. We needed both a teacher and a pusher. So we find we had very many good ideas, which we share, but we had no one to really push, who had the drive to actually push and get them done. The other thing he mentioned is in terms of infrastructure and funding. We have kept on struggling with where does the funding for antimicrobial stewardship activities fall. So I know last year we wanted to have a training, we couldn't find nobody, we were like orphans, nobody would agree to host us in their budget. We're not in a budget for anything. We're kind enough that that was 2 years ago, our then director of pharmaceutical services took a bit of money from the drug budget to be able to support an AMS activity. But it is very challenging if you don't have leadership support. So we worked at how to make sure that the interventions you have, that these they touch on whether it's a hospital performance contract. I don't know whether Mogere you have a performance contracts system. So I keep insisting, if there's no way that AMS is stuck to performance appraisal, it'll be very difficult for you to achieve. And when the leader, if I think of our MTC, Medicine Therapeutics Committee, we had one leader before who now, when they left, we didn't have anybody who was really committed to drive the agenda of the MTC, so the committee died. So you need to identify your leader very well. You can have somebody very bright, but they need to also have the drive and have that capacity to push for the agenda, the AMS agenda to be there. And I would encourage you, it takes a while. We've taken a while, actually, said my colleagues, now sometimes you feel you're overwhelmed by a leader that it almost feels like AMS is a full-time job, and yet you have, it's not the only thing you do in the hospital. So the good thing of, yes, you have somebody who has drive, but now you also don't have the time, you're not fully employed only to do one activity. He asked about qualified, the inadequate qualified staff. Majority of setups don't have labs. So we don't have laboratory. I'm hoping that MTAP's program could you be able to link such facilities to, I think there's a program related to MSH that has to do with IDDS. I can't remember what it means in full, but to build capacity. For our institution, we had a lab, but would have, as much as it's a referral hospital, would have the challenge of we don't have culture bottles. So you go a whole quarter, the lab didn't have, maybe funding was cut, so they didn't have, or the supplier failed to supply, and that whole process of waiting for 1 month before you move to the next person, so you compromise the standards. But now, fortunately, through the Fleming Fund, it has taken direct interest in being able to build capacity, and I believe it's also to build capacity in other facilities. But you can look for which partner can you be able to engage. And I would hope that KEFA, maybe PSK, MTAPs, if you can look at a way for those who have fledgling AMS program, how can we support to link them up to those who can support? Because a number of times I see grants, people, expression of interest, or people having grants that they want to support AMS activities. So you see how can you tie in so that your facility is picked up for upgrade or for putting in these systems. And yes, it is frustrating working for government, but I will just tell you, just look for something that you don't try and bite everything together. Just look for something that works, can work, that can give you a sense of victory, and take that victory, that you sing about that victory, so that it encourages the institution to take that up. I want to hope that that has helped you, Kefa. I'm not too sure, but I'm sure it is not very hard it's actually not hard at all to reach myself or anyone in Kenyatta. If you think maybe coming to see what it is we do and see what you can borrow, and it helps you work better, you could reach out to anyone in KNH and we can see how we can assist.
Thanks, Dr. York, for those very practical tips. So Velma has confirmed that she meant culture and sensitivity tests, equipment. So, and I believe there are quite a number of healthcare facilities in Kenya that whose lab capacity is still wanting, for lack of a better word. So, how best can we have proper stewardship activities in such healthcare facilities?
I would say where you don't have lab capacity, you need to see, can you plug in, sounds like it is government. So if we can, they are county antimicrobial interagency committees. Can we plug into those committees, reach out to who are in those county committees, so that we can insist that we have this, we upgrade our lab. Does even is at the lab, is your lab, your MS the lab person? Are they vocal, or can you encourage them to be vocal, hoping that that doesn't mean that they will be transferred out of the institution? But can you find a way to vocalize that to management so that it is pushed as an agenda? If you sing the success story of another, because you find if you borrow a success story and bring it, and so somebody sees how this can work, then hopefully now it can help you also implement the same in your facility. And I to hope that Collins, you probably could be able to respond, because I think there's a program which somehow a message is connected with IDDS, or which something that seemed like more targeted towards building laboratory capacity. If such institutions, maybe work with PSK, see how we can reach out to those of our colleagues in the other government facilities and see how can they support them now that the need has been identified. Velma was asking about, it's the same thing, microbial culture and sensitivity.
Yes.
Yeah.
Yes, thank you for that referral. Yes, we could refer them and assist where necessary. I also want to say that when you receive a prescription or a treatment sheet and there is an inappropriate dose and you call the prescriber, or there is an inappropriate frequency, that is still stewardship. Yeah, you're ensuring appropriate use of antimicrobials. If you decide you want to audit, patients who were treated with pneumonia last month in the inpatient or in the outpatient against guidelines, that is stewardship. And seeing to what extent our patients will be managed correctly and giving feedback to prescribers, that is still stewardship. So there are various ways that you could have stewardship in a facility, even if you do not have lab capacity. I want to proceed on. Dr. Oscar Goro from Nyeri County, the AMS focal person, Nyeri County, says, thank you for the good presentation. And then he has a couple of points and a question. So one, he says that ensure continued public and patient education on the need for rational use of antimicrobials. This can gradually reduce, the pressure exerted by patients that leads to overprescribing by doctors. He goes ahead to say that there's also need to have clear policies on how to engage pharmaceutical representatives who largely influence prescribing in our hospitals. I believe most of us will agree to that. Number 3, he says it's important to strengthen commodity management to improve availability of antimicrobials. Sometimes prescribers are forced to prescribe what is available in the facility, or those antibiotics, that have a short expiry. And I think this is a common trend in the typical health facility where, in the pharmacy, we have a few tablets of cefixime remaining or a few bottles. And so we'll let the prescribers, and that afternoon or that day, that is all that they'll be prescribing so that, we clear the stock and we avoid, these antimicrobials expiring in our shelves. Then he reiterates what Dorothy, I think, has really talked about this evening, that AMS leadership is critical and very, very important. I think you have talked about it being assertive, clearly articulating the need for stewardship, and it starts by having the passion to make a difference where we work and for serving our patients. Then his question is, how do you get the involvement of physicians and MOs? It has been a bit difficult for us. So what's your advice, Dorothy? How do we get the physicians and the medical officers get involved in stewardship activities?
Okay, thank you very much, Oscar. There's a lot he says that it's like almost like deja vu. I feel like, yes, I remember that scenario. So how do we get involved? We found you have to get it's like advertising. You have to get the champion, the person who they will listen to. So we have very what is it? The people with good skills, but they I don't know whether I'd say, I don't know how to professionally say charming. There are those charming personalities. Not saying you go get a news presenter or an actor, but there are those within every specialty. There's that pediatrician who you'll find most of the pediatricians listen to. You may have to take some bit of time to identify. There's always a physician, a clinician, there's somebody who they will listen to. So now the easiest is to be able to, how can you get that person on your side? Then they are the ones who will draw in the other physicians and MOs. And it's even when you get them on your side, sometimes it still be difficult, because if I give back the example of hospital KNH, our lead is very vocal, Dr. Cheng, but we'll post something related to an AMS intervention in the group for the consultant forum. And we're hoping that we can start a discussion around that area. But then the next post will be something, maybe related to COVID and the bars or something, so they would lose the track. But you just have to keep finding, you find even when we are having, maybe you find a way to structure, was there a joke running in the forum, and you find a way to insert your message to flow with that joke, and from there hopefully start a conversation. Sometimes you find you will not get the whole group moving with you, but somebody might direct message you, and from there you can be able to access the team that they influence. But unless you, for Oscar, unless you identify influencers in your facility, it's going to be difficult when you try to do it alone, particularly as a pharmacist trying to reach out to the physicians. You can, unless you can get those ones who I find it's easy to work with, the ones who are my classmates. Talk to the ones who are my classmates in undergrad, get them on your team, then they help you, introduce you to the ones who are the opinion leaders, get them on your team, and now it's basically, you'll be like, they'll be your mouthpiece. You give them the message and they say it to the in the various forums. So it is hard, but you need to be patient. I said our MS stewardship committee was formed in 2013. And the time when I've started feeling like we have actually started being heard is maybe around 2017, 2018. So it has taken some time. I would not think that we were really that, we were making such an impact until around 2017, 2016, 17. So just be patient with yourself, and also see what other people doing. What is like Aga Khan University Hospital doing Is there somebody there who has good access to somebody in your facility? Sometimes you might have to go across to come back to your facility. Do you have a physician in another hospital who now maybe through their medical association can share your message, and somehow they will come telling you your message from a training or a CME they had, but they didn't know that your message actually went to another facility before it came back. I want to hope, and then he talked about how to engage pharmaceutical representatives. These days, at least for the multinationals, the issue of antimicrobial stewardship is very key. So we find for the multinationals, they don't tend to be pushers of their medication. We struggle more with those who are not probably bound by the same code of ethics as the multinationals, who have to be very careful about how they present themselves. But we know either way that we have guidelines in our we encourage. In fact, you keep on saying that okay, yes, you may want to prescribe outside the guideline, but this is what we require, and you need to give evidence for why why you have to go off the guideline. And with time, that has improved. I want to hope I have answered all of Oscar's.
Great. I think I need to read this from Kefa, just giving feedback. He says, thanks, Dr. Dorothy. I think you're a wonderful speaker. I have gotten energized again. I will introduce performance appraisal system to see whether it will work together with other approaches you have mentioned in the presentation. Thank you. Thanks, Kefa, for that immediate feedback. One question from Dr. Githinji in Kajiado. Thanks, Dr. Aywak. Do you mind sharing a sample of the treatment sheet that you described earlier, which the prescriber has to write if the antibiotic is empiric or otherwise? Will you be able to do that, Dr. Aywak?
Yes, I can, but I don't know how. I don't know if PSK will circulate this presentation. Collins, are you circulating the presentation? Or maybe what you can do, I can just, yes. I think I put in the chat my email, and he can email, and I can share with him the presentation. I can share with him our treatment sheet. So the email is very easy. Dot like the punctuation. Okay. .aywak@gmail. So I'll just put that in the chat box. So just email, and then I'll email you the treatment sheet. Just let me know that you had wanted the treatment sheet, and then I will send you now the image so that you can be able to see how you can utilize the same and adopt something similar.
Thanks. In terms of the slides, I know a couple of people have asked. We will fine tune them and then in due course share them. There is a question from Gerald Wara. Please comment about the One Health approach to antimicrobial resistance. Very nice presentation. So just
thank you. That Dr. Wara is my classmate, and I think he has actually also attended almost 1 week training on the One Health approach. So he may be able to even talk about it. But One Health approach looks at, you don't look at antimicrobial use as just that it is only being used in human health. You need to consider that there's animal health and plant, the food and environment, where antimicrobials are used. So when you're looking even at your patients, especially those who are in, probably if you're in an agricultural setting, you need to think to yourself, they could be, the patient you're seeing could be heavily using antimicrobial agents, either as growth promoters or the like, as weed killers in their farm, and they are coming with an infection, and because they have already been inadvertently exposing themselves to antimicrobials, it's going to be a challenge when it comes to managing them. So we don't look at antimicrobials as agents that we only using in health sector, even in animal sector, in plant and environment. So that's why it's important that when you're doing when you're setting up your interventions, you need to look at what setting are you in, and also partner with those in the others. For agricultural, there's food and the FAO, Food and Agricultural Association, and the Organization of Animals, OIE.
OIE, yes.
Yeah, of animal health. And I think the National Interagency Committee has representation of both. So that now you have interventions targeted. If you're in the farm sector, you need to see, oh, somebody's a farmer. You could even just have an informal conversation. What are they using in terms of managing their crops or animals? And there you can have an entry point to share the message and let them know that actually what you're putting in the ground eventually can come back and bite you, because it will interfere with being able to manage you.
Great. A final comment from Dr. Goro that it is very key to strengthen the link between the lab, pharmacy, and prescribers. I think you'd mentioned that, Dr. Aywak.
Yes.
These need to work together for the success of a facility level AMS program.
Yeah, I agree.
Great. Any additional questions, comments?
I'm seeing the chat function flashing, so I don't know whether people are putting questions there. I'm seeing Gary Collins. Which instances the current coronavirus 2019 pandemic could affect antimicrobial stewardship activities and drive antimicrobial resistance? I'd say what we've seen clearly is the prescriptions for azithromycin. I don't know whether they are prophylactic or what, but you start noticing azithromycin is just being, consumption of azithromycin just started to really move up. And then, there's fear what to prescribe for the patients who are infected. But one thing that was very clear that when you hear WHO or FDA recommending a particular treatment, the consumption of that you start noticing that there's some increase in that consumption. At some point, there was a lot of patients who are on amoxiclav, azithromycin, or something with plus azithromycin. So that's something that we were able to see when you look at the antimicrobial consumption.
Thanks. I missed that. Nandi appears to have a keen eye. That's Nandi Philip Harold. He says, your screen depicts the dispenser, supposedly a pharmacist, giving unpacked and labeled medicines contrary to dispensing good practice.
Very interesting
Thanks.
you picked that up. I was actually going to ask you, Collins, after you finish that, what are you trying to show in terms of pharmacy practice through a window? We don't even have an envelope. So thank you for the keen eye.
My sincere apology for that. We will work on our branding for the slides. Any other question from any quarter?
I want to hope that we have responded to all.
There's a question actually from Kariabuya. How does KNH handle incorrect use of antimicrobial misuse from lower facilities that refer clients to the facility for better care? Are you able to pick an appropriate use, and do you have a feedback mechanism?
As yet, I think the closest we can say to feedback is when there are sessions like this or other webinars where now you share what it is you're seeing, but we've not, I cannot say that as an institution, we will go and, I cannot say that as an institution, we will be going to talk to a facility, but we have that mentorship program, like facilities which reach out. I know Machakos has reached out. So you look, if there are patients who are coming, in fact, we joked with them. We've been saying what we see from Machakos is the ambulances bringing their patients. As opposed to now the part of care. But now when we have opportunities, maybe if you're invited to an institution or they want to come and see what we are doing, we share what it is. If we have information, we've not been collecting data in terms of what is happening in the county. We share that information. So I don't know whether that helps. Abuya.
Yeah, I believe that helps. And I think it's a very, good point in the sense that if there's a way you would be able to track, when patients are brought in and you capture gaps, if over time you could be able to give them feedback, either one-on-one through phone, or even if it is through a talk, by going to the particular facility and saying that, hey, we have noted this trend and we just wanted to understand more and see if we could support you. That could be something that, you could explore if possible.
You've given us what is in one of those core elements, action intervention that we need to look into.
Correct. Dr. Gemini from Aga Khan, are pharmacy schools going to include AMR in pharmacy curriculum since this is the way forward? I think I can respond to that. As USAID MTOPS, we are working with the School of Pharmacy, University of Nairobi to develop. Actually, we have already come up with a curriculum focusing on antimicrobial stewardship. And of course, it starts with a module on AMR in particular. We are just at the point of implementing the curriculum, but it is actually ready as we speak. Dr. Mugoi from Aga Khan asks, hi Doc, please comment on the insurgency of H. pylori resistant and what are some of the mitigating interventions as an AMS steward? Please comment on the insurgency of H. pylori resistance and what are some of the mitigating interventions as an AMS steward?
Well, off the heart, I don't have any intervention in mind. I don't know whether anyone who is following can be able to help us respond to this question. I'd have to think about it and ask the rest of my team. I know Dr. Rosalind Kibuthia is with us, is our pharmacy lead. Whether she'd be having anything to comment on this, she could put in the chat. But for Dr. Mugoe, I don't have a response for you. But if anyone has feedback on this question, I'd encourage them to assist me to respond to it.
Sure. That is a good comment. Dr. Timothy Panga, this is definitely our calling and our greatest link to public health. I urge everyone to have a strong interest in AMR, AMS. Thank you, Dr. Panga. Great. I think if we do not have any more questions, I would like to bring this evening's talk to a close. Thank you very, very much, Dr. Dorothy Aywak, for the presentation and for your insights in terms of antimicrobial stewardship and what you're doing at KNH to ensure that there is appropriate use of antimicrobials. Next month, we will have part 4 of this series. We will let you know in due course. I don't know if Dr. Ndinda Kusu, the Country Project Director, USAID MTOPS, is still online. You could probably just say a word or two and we'll bring this talk to a close.
Sorry, Dr. Jaguga, I'm seeing some 2 questions, which since you say Dr. Kusu is online, from Naomi Keino, if there's a protocol you use to monitor patients coming in with AMR and maybe they're not even aware and being given the same antibiotics. And okay, this one, we don't have a protocol, but I think in terms of good history taking, but this is one from Spencer regarding funding for AMR stewardship. I would hope Dr. Kusu can be able to help how to build, to engage facilities or be able to reach out to facilities so there can be funding for AMR stewardship. But for institutional leaders, we find when another organization comes and wants to audit what is in practice, it sort of triggers them to set up a committee. Like if I say MTAPS comes and wants to know what we have with regards to AMS program, I think that when they did an assessment and asked, do we have a policies, when we realized we don't have a policy and now we came up with one. So for Spencer's question, if Dr. Kusu can be able to handle it and even issues around how to build capacity around there. But otherwise, thank you for those who are my students and interns and have joined in, and I appreciate you taking time to be with us this evening.
Thank you very much, Dr. Aywak. Dr. Jaguga and the PSK leadership and everyone who is online, really joining hands with the PSK leadership to celebrate the WA Week in style as we discuss these core elements of antimicrobial stewardship. Indeed, it's also been a good learning opportunity for me. And I'm so happy that this presentation is really in line with the theme and the slogan for this year's World Antimicrobial Awareness Week. And I really would want to urge all of us to handle antimicrobials with care, first as pharmacists, as professionals, but also take the opportunity to educate others, our colleagues, our other healthcare providers, and also our patients and consumers. So I'm really rallying the call for us to all unite, and even that facilitate multidisciplinary teams to ensure that preserve antimicrobials. On the question that was asked, if you can hear me, Collins, I'm audible?
Yes, you are.
Yeah, okay, thank you. So on the question on funding AMR stewardship activities, I would say just like any other field right now, the funding is of course varying. We have reduction in funding across many areas, but the opportunity for us under AMR is that there are many things that we can start small. And if I was a good student, as Dr. Aywak was, sharing, there are things that we can actually be able to do, right from, doing prescription review, antibiotic audits, whether it's in a facility, in a pharmacy, and in a facility, just engaging our fellow, colleagues within the MTCs or within the multidisciplinary teams to come up with some of those antibiotic strategies. So it's variable. It's something we can take offline aspect, but there are a lot around antimicrobial stewardship that we can all do. And I would really encourage each and every one of us to be antimicrobial stewards. So I'll end there, apparently so, and just really congratulate, thank PSK for taking on leadership for very empowering sessions, these ones and even beyond AMR. Thank you, Collins. Over.
Thank you very much, Dr. Kusu. Thank you once again, Dr. Aywak. At this point, I would like to hand over to the Communications Officer, PSK, Dr. Mbao Gitau. Welcome, Dr. Gitau.
Asanteni sana, Dr. Collins Jaguga, my seniors in the profession, Dr. Dinda Kusu, and Dr. Dorothy Aywak. I will not delve much into what has been discussed today, but I'll request my senior and a member of the National Executive Council at the Pharmaceutical Society of Kenya, Dr. Timothy Panga, to probably pass his word, to give the PSK a vote of thanks due to the continued support we have gotten from MTAPs and USAID. Dr. Timothy Panga, kindly give your vote of thanks on behalf of PSK. After that, the event is, we call the evening a close. Dr. Timothy Panga, over to you.
Thank you so much, Dr. Mbao, for the ambush. I really got in as a learner and as an interested member of this profession and also of the healthcare team. But thank you for, I think you spotted me as a member of the NEC, and I want to thank Dr. Dorothy Aywak for her very good presentation and for raising our interest in getting our hospitals to deliver on this fight to prevent or at least to decelerate the advent of antimicrobial resistance. And we in public sector, of course, have a lot of mileage to a lot of way to go. And we are already, picking up. Several centers across the country are really picking up, and getting their microbiology working, getting their IDs working, and sensitivity testing working, and getting the interest of other team members, and having pharmacists leading. And as I mentioned in my comment, this is really a place where the pharmacist role really joins in to the broader health system, and probably even wilder global goals. So I think that's something we can take up, and we are happy that there's leadership at MTAPS, very strong pharmacy leadership there. And there's also leadership at our referral hospital level, National Referral Hospital, which prominently features pharmacists. And I think this will really help us. So thank you so much. I want to thank you all for attending. And as we continue in this fight, I urge everyone, whether clinical or in administrative or in public health aspects of pharmacy, to join in this fight. It will be rewarding to you as individual, and it will most importantly benefit patients, benefit the public, and lead us to a better, safer world where antibiotics continue to reduce the human suffering that comes through infections. Otherwise, thank you so much.
Asanteni all, and have a good night.
Thank you.
Pass your regards by the chat box as you leave.